Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
So listen, Alan, you seem to resonate in one of our podcasts about the quote by Sid Blatt, who said he is at his best as a human being when he does therapy, and something clicked within you. And if this at all parallels what happens in therapy, because you were making the point that therapy happens all over the place, then maybe we should start with that and figure out what happened with you.
Well, it was amazing. And I've thought about it a lot, and I'm not sure I understand it very well. Maybe you can help analyze it for me. But I've always known that I love doing therapy. I've also always known that I was very grateful to patients. Whenever I wrote a book, I would dedicate it to patients because I felt they taught me more than anything. But I never understood why I loved it so much and why I was so grateful to patients. And then when you mentioned this comment that Sid made, it shed a whole new light on my entire life and career, that I was much better as a therapist than I was in any of my other roles. And that was, it changed the way I saw myself. It revised the last 45 years of my life, and all that happened in one sentence.
Really? And you got it for free also. But so the question is, this is fascinating. And we both know, and people who do therapy know, that sometimes we say things and we have no idea what impact it's going to make. And then weeks or months later, the patient will say, you said something in a session, and then repeats it, and we don't remember that we even said it. So our notion of what makes an impact doesn't always match up with what makes an impact.
Well, my career is a real demonstration of that. I've always worked in emergency rooms. Whatever my other responsibilities were, ever since 1973, I've always spent 2 or 3 days a week in the morning supervising in the emergency room and seeing for 10 or 15 minutes any patients who were still there from the night before. It's been remarkable to me how often people would approach me years later and say, you may not remember me, but you said something that night that changed my life. Now, the contrast to that is I've also done a lot of long-term therapy with people, with one patient for 14 years, with many patients for years, and felt that nothing happened. So there were magic moments sometimes in the emergency room that could change people's lives in 15 minutes. And then there were years of work with other people that seemed not to do very much at all.
But I have to tell you, I don't believe in magic. I believe in process. And I have a faith that if we get enough smart clinicians together with enough astute researchers, we can figure out what the process is. So let's, at least between the two of us, go back.
I disagree with that.
Oh, okay.
We don't have many disagreements in the world, but I don't think this is measurable.
But we're just starting our podcast, so we don't really know.
Yeah, I don't think this is measurable. I think there's something about it that's so special and so ideographic that would be hard to put numbers to it.
Okay. Well, you don't have to have numbers, but let's play with it. Let's see. So let's go back to your example. And the way you put it just a little while ago was, those words, I'm at my best as a human being, captured what? It captured experiences that you have had over a period of time. So here is a word, and this is the talking cue, or a label that somehow encompasses experience. So to my mind, what this says is our words in therapy need to have, quote, meaning, in the sense that the person has to have a referent. The word has to be linked up to an experience.
And I think it has to be poetic.
Well, I'm not sure I agree. Let me give you an example, and you tell me if this is poetic, okay? I don't know. Do you downhill ski?
No.
You never did. Okay. One of the things about skiing is that when you learn, you have to learn how to just correctly bend your knees and put the weight on the different skis. So I remember getting a lesson with this Austrian ski instructor who kept yelling, "Bend the knees, bend the knees." And I'm bending the knees, and I'm sliding and falling, and I'm getting really irritated. I'm thinking, I'm bending my knees. And then after a period of time and some practice, I bent my knees in just the right way, and I was skiing. At which point I thought, oh, bend the knees. The words that he told me did not link up to any experience that I had. But once it did, it was magic. Well, it was not
magic. You said
but it wasn't poetic.
It was bodily poetic.
Bodily. It was prose, but that's okay. Well, the biggest obstacle that we have is the use of words, and I've mentioned that before. But, and that's why specific examples, either clinical or other anecdotal things, or observing something on a video is a better way for us to understand what goes on. So let's go back. Go ahead. You want to say
another example from my life, and then to add to your clinical material and your analysis. My first patient, the outpatient, in 1968, I had a supervisor who was a real tight ass. And I had to copy every word that I was saying and every word he was saying and present process notes so he could understand what was going on in the session. The treatment was an absolute disaster. I wound up saying almost nothing because I was always afraid that whatever I said was always wrong. So I wound up saying very little. It was a disastrous waste of treatment. I feel guilty to this day. I had my second patient, I had a supervisor who didn't want any notes. In fact, he didn't care what the patient said. All he cared about was what I felt toward the patient. And to liberate me in the room to be myself and to be with the patient. And that patient did remarkably well in a very short period of time. And I realized how stupid my first supervision was, and how stupid I was to follow his instructions. And that changed the way I saw the whole world of therapy. Yeah. That the relationship was going to be very, very important, that the mesh of the two personalities was going to matter a great deal, that it wasn't, like being so careful with each moment. It was the whole result of the experience. Another kind of magic moment.
Let me, on that point of how you feel toward the patient, I agree. It's a little bit off of what we're talking about, but I think it's important enough to touch on this. There was some research done, I don't remember when, probably in the 50s. I've never been able to track down the reference to it. There was a correlation between liking of patient and therapy outcome. And in my supervision, when I asked my supervisees to write up notes and case formulation, I asked them to rate on a 5-point scale, how much do you like this person? And if it's less than 5, we explore why not. Why don't you like? What are they doing? And is there a different way you can look at what they're doing so that you're not disliking them? But so I do agree that liking of the patient is essential. But I really want to get back to the.
Well, let me just interrupt you because I want to emphasize that point because I think it's such a great point. I had another experience early in my career treating someone I didn't like. And I presented her to several different people, hoping that someone would say, stop seeing her. And then one person I presented her to explained to me why I didn't like her. I realized it was me, it wasn't her. It was my problem. It wasn't she was unlikable. It was I had a problem liking her. The treatment then blossomed, a magic moment again in supervision.
Yeah. Oh, boy. I mean, I don't know what to say next because I have a choice of about 5 or 10 different things to say. Okay. Okay, I'll give you a clinical example because these always I think, drive the point home more vividly. I was supervising a graduate student who was working with an adolescent whose mother was overprotective. And she had sessions with the mom and trying to get the mom to give more autonomy to her daughter. But she was like, who are you dating? What are they like? And I want to hear everything that goes on. And it created a lot of conflict. So it was really an issue between the mom and the daughter. And my supervisee was really irritated with the mom. And the mom would not listen to her. And I said, maybe you need to understand the mom a little bit more. And then we got into it. And it turned out that the mom had a history of sexual abuse by men. And she was very, very worried that this could happen to her daughter. And I got the supervisee to try to understand and like the mom more. What's this like? You know, you have a child and you had a bad experience and you want to protect your child. What must she be feeling? And the more she did that, the more compassion she had for the mom. And within the context of compassion, she explained to the mom and got the mom to ease off a bit. So the liking of the patient, or in this case, the mom, is essential. You have to have a real clear mind and a lot of knowledge in order to figure out what's going on in a session. And if you don't like the person, that's noise. It interferes. So
it's really interesting. So far, in just a few minutes, we provided 3 different types of magic moments. One type that comes, well, 4 types. One type from me here, just hearing a sentence that you utter. Another type, what happens in a therapy session when you say something to a patient that crystallizes experience that they never really understood before.
Right.
The third is as a supervisee, learning from your supervisor.
Right.
In a magic moment. And you're presenting another interesting case where, as a supervisor, you can create a magic moment for your trainee that may last not just for that one patient, but for the rest of their career.
Yes. Yeah. And at some point, we'll talk about supervision and how it's similar to and different from therapy. But yeah, the magic moment is I think we need to not only have magic moments, we need to have take-home messages. And the take-home message that your experience and my experience with skiing and my experience with patients is that if you use words, the words have to have meaning to the patient. And if they don't have meaning, it's not going to make an impact. So if you say to a patient, simply because you have an argument, people don't have to like you. People can have an argument and still be okay. Well, if the person has not had that experience, then those words don't have a reference. The person is not bending their knees in the right way. So we need to know the person's experience if we can, and then match up the right words.
That's what I call poetry.
Well, you can call it poetry. I call it good therapy. But also there's the notion of an interpretation, and that is an X-rated term within CBT. We don't talk about interpretations. We don't talk about insights. We talk about awareness, and whatever that means.
And I think there's a very crucial, to me, the most crucial take-home message from this is that every session with every patient, every session with every supervisor is a potential for these kinds of magic moments, that it's never routine, that lots of sessions may not do much. Lots of sessions may actually be routine, but you never know that beforehand.
Right.
And even though you're tired, you've seen 10 other patients, and for you, it seems, just the last patient of the day. For the patient, it's always a very important experience seeing us.
Yeah.
And it possible, just possible, that if we say the right thing in the right time, in the right way, at the right moment in our relationship, that we may make a difference that will be so important for the rest of the person's life. So we need to be on the alert for those special moments and find ways of expressing them poetically enough that the person can hear them.
So how do we know what's quote right? Now, you could say, well, it takes a lot of experience. Well, that's good, but that doesn't help a supervisee. You know, to say to the supervisee, wait, one day you'll know, 20 years from now, you'll know. They want to know now. Can we specify this? Can we capture this clinical wisdom, the clinical magic? And magic, you know, if you go online, and I was just did this the other day, went online on how magic occurs, the secret behind magic tricks. So what's the secret behind the magic in therapy for any given individual? Well, I feel it has to do with a very careful assessment and case formulation. You've got to know the person's quote button that gets pressed. So there's the button, and then there's the person that presses it. And the button is a sense of vulnerability based on early experience.
What's interesting, again, I think we both agree completely, but with slightly different emphasis. So I agree completely with what you're saying, but I also think a lot of it comes from the person's prior experiences in life, everything they've done before. I would always tell new trainees, you know, they'd say, how can I go see a new patient? I don't know anything. I tell them, you've been preparing for this for the last 25 years, that every experience you've had up to this point is an experience you're going to be using now. And it's not like a trainee begins from ground zero. We can help push them forward in their awareness. But a lot of what needs to be said in that magic moment, they know. They know from every interpersonal experience they've ever had. And if they've been selected well into the program, they're going to be pretty natural at it.
Yeah, but their experience may not parallel the patient's experience. And we know this now loud and clear, that the racial, ethnic, sexual orientation, background, et cetera, these are all play a very important role in our ability to know what's going on. And sometimes our experience does not match up to the other person's experience.
Completely agree with that.
So,
so training is also very important.
Yes.
But it sort of training is neither is completely necessary or completely sufficient. Life experience and who the person is, very important contributor. Training, a very important contributor. But to really get the best in a therapist, you need the combination of both. Actually, that's worth talking about next week, I think, in more detail. Maybe
that's the question of training. Exactly. Yeah, that's the question of training.
We'll do that for next week, maybe.
And my thoughts on that is our method of training is very 20th century. We are not making use of the capabilities we now have. You can say, well, you know, it's clinical experience. Actually, I don't like the term clinical experience. I like the term clinical observation, which is less inferential. You get 100 clinicians together and you say, have you observed X? Have you observed that there are times when the patient's problem manifests itself in the interaction? And if you get 99% of those individuals saying, yes, I had that clinical observation. Well, to my mind, that's evidence. Okay, but now this is more theoretical. How can we, in the 20th century, it was not easy to get the experience of 100, or the observations of 100 practicing clinicians. Now it's very easy. You just go online, you show a clinical vignette, and you say, has this ever happened to you in sessions? And if it is, then this could be wonderful for trainees. They don't have to wait 20 years.
I was just going to say that this is such a great topic and a big topic. Let's save it for one or maybe several sessions beginning next week.
Okay.
One other thing on this topic, and we don't have too much more time, that I wanted to bring up was a paper that a friend of mine wrote. His name is Yutaka Ono. He brought cognitive behavior therapy to Japan. And he wrote a wonderful paper about 10, 15 years ago called Zen and the Art of Psychotherapy. The point he made that I think is crucial is that in Zen, you don't expect that the amount of practice you do will necessarily make you perfect. It's understanding it. It's kind of a Gestalt moment.
Yeah.
And in flower arrangement, Zen activities like flower arrangement or archery or the tea ceremony, nothing seems to happen, but everything happens. And the reason for that is the very high expectations on both sides that something good can happen, that something memorable is happening. And I think that the lesson for therapists is, again, that ripeness is all, that you're not sitting passively in your chair and the sessions go by and you don't feel compelled to do something interesting. It's very important to be able to get the patient's attention. And it's very important to heighten the patient's sense that something useful can happen. If there's going to be a magic moment, both people have to believe that what's happening between them is important, that it matters. And a lot of that is the way we prepare our patients, the way we prepare ourselves for the sessions, to see each session as potentially very important in that person's life. Marvin, you're speechless. I've never seen this before.
I mean, I agree with you, but listen, I have to confess, I am basically methodologically a Skinnerian. I never thought I was, and only in recent years have I recognized. And what do I mean by that? I've got to be able to see it. I've got to be able to measure it.
Right.
I've got to be able to see it. It's not only insofar as research is concerned, but I have to be able to see it in the session. Because what that does is I pick up on things in the session, and that becomes what some people call a marker or a significant clinical observation that then triggers something in me. And what it triggers in me is, okay, my experience, my knowledge of doing therapy, my teaching, my research, other people's research, it triggers, and then it says, here's what I need to do. And it's a complex process.
This is really fascinating, because I think probably in sessions we're a lot more alike than we are different. But in conceiving of what we do, I see an enormous difference in how we conceive of it, even though practically we're probably pretty much alike. I think you're much more of a methodologist, and I'm much more of a romantic. You're much more wanting to build an edifice of knowledge about what's happening and how it happens. And I'm much more for the intuitive moment.
Yeah, I didn't have as powerful a psychoanalytic background that you have.
I don't think it's that. I think it's our personalities.
Well, I don't know. I once gave a lecture in front of an audience that was primarily psychodynamic. And I was talking about the change process. And during the comments in the Q&A, what I noticed is that the way they phrased their questions and comments was from a phenomenological point of view. And I think phenomenology is important. You have to have that, to have good empathy, to have good passion, but you also need to know the operations. So you've got to go back and forth. You've got to be involved subjectively, but also look at it objectively. And it's taken me, 50 years before I had my aha experience. And my aha experience is, now I know what Harry Stack Sullivan meant when he said the therapist is a participant observer. The therapist is experiential, subjective, but also can step back and observe.
Well, it goes to a distinction that Kant made 220 years ago between nomothetic and ideographic.
Uh-huh.
And I think the idea being that some things are much easier to put into scientific terms and to measure, Other things are much more individual and specific to that one situation. We're both. We both do research and we're both clinicians. But I think that what we'll bring that's different to these discussions is that you'll keep us more grounded in methodology and in the nomothetic, and I'll be flying off the handle every once in a while with my romantic, intuitive notions.
Well, okay, so here I can disagree with you, because if B.F. Skinner were here now, and B.F. Skinner, we can both agree, was a methodologist, okay? We agree on that? Science, methodology?
Sure.
But he was very ideographic.
That's right.
And he said, nobody goes to the circus to see the average dog jump through the average hoop.
Right.
So I don't think it necessarily is that there's an antagonism.
That's exactly right. We agree completely. And each person, each patient is an N of one experiment.
This is a good place to stop.
Okay.
Okay. This is a lot of fun. I really enjoyed it.
Always fun.
Take care.
See you,
Stay
Marvin.
safe.
Bye-bye.
Bye-bye.